visible with ultrasound, and these are a lot of spots where pain is generated, and you could do a trigger point injection not only in muscles, you can do that in ligaments, and this is some sort of outlook. But if you know all those ligaments, there's no hindrance to show them. You can, every part of that ligament is visible. This is one of those ligaments. That's the posterior long sacroiliac ligament. Why do I show that to you? That's a landmark for the middle cluneal nerves, by the way, if you want. Nobody has tried that, but I know that they are right on top of them, so you could use it at landmarks. Next, if you have problems with the middle cluneal nerves. Next, please. And another problem, next, is the delineation of musculature and ligaments. And if you see that the erector spinae muscles, this is the mass of the sacroiliac interosseous ligaments, and they're clearly seen as hyperechoic in a triangular shape. And if you put your needle here, you end up in the ligamentous mass. You're not ending up in the joint gap of the iliosacral joint. You have to go more caudally. That does not mean that it doesn't work, because a lot of pain is generated coming from the ligaments and not from the joint space. So that's a good method, but you have to distinguish between the one and the other. Next, please. And if we respect limits, sometimes, although I know you can't always get what you want, sometimes you get what you need. That means that's what I said a few minutes before. For example, if you use the Taylor approach between L5 and S1, almost always there is a chance to see the ligamentum flavum and go to the epidural space, even though if you don't see the rest. So that's an option, and it's sometimes the solution to the problem. If all the other windows are closed, you can use that because it's regularly the widest window between the laminae of L5 and S1. Next, please. And last but not least, be aware of the fact that not always, I'm just coming from Japan, by the way, a lot of nice people, and they're all slim. Or in Chinese population, the same. This is what we have to face, and probably you in the USA also. And there is no chance, absolutely no chance to do a transforaminal injection whatsoever. And this is a very good image of a very obese patient. But in many instances, you can't see anything. So you don't use ultrasound, just use what or do what makes sense. Next, please. And last but not least, we can have dreams, for example, being more exact in that area. There's something Semina Ruz is very, very experienced about. If you go epidural in that area, and I know not a lot of people do ultrasound-guided epidural cervical interventions, but if you want to look in the future, you see, we can get images that are absolutely clear. For example, you see the dura, you even see the central canal in the spinal cord. And if you do a transverse section, almost transverse next, you can even see the mass, the lateral mass of atlas, you can see the spinal cord or roots, etc. That does not mean that you should use that in your patients, but it's an outlook of what is possible in that area. And this is with our development of ultrasound in using the spine. And last but not least, you also could go to the discs, but be aware where it is or where you have to approach, because not so well known, there are hindrances caused by the uncinate processes. They are very typical in the cervical areas. You could not see anything here, just if you go in front. But be aware, wherever you go in that area, a lot of vessels, not only the common carotid or other important arterial structures that have to be recognized. Next, please. And this is the end of my talk, and I hope I have saved a little bit of time to have time for discussion, and I thank you for your kind attention.
Thank you. So I think we did a good job. We still have 10 minutes for questions because we incorporated the videos within the actual presentation.